Move on now because I'm sure everyone's in need of a coffee, so I'll try and get through my slides relatively quickly. So I'm going to talk about the investigation, the treatment, and the diagnosis of long QT syndrome all in about 20 minutes, if I can. So as we know, long QT syndrome is an inherited cardiac disorder, and we think the prevalence of the condition in the population is about 1 in every 2,500 people have the condition. When many people hear that, they're quite surprised, so it's more common than cystic fibrosis, more common than sickle cell disease. So it is probably more prevalent than we perhaps first realized. And that's because many people who have the condition, as we know, go through life without ever having any symptoms at all. And that's because the penetrance of the disease is relatively low. So not everyone who has a genetic change may ever display any signs of the condition whatsoever. As we've heard about, as we know that the key to the investigations lies in the family, but in long QT syndrome, it's in the demonstration of key features on the electrocardiogram and in the history. And genetic testing, as we've already talked about this morning, is an important supportive investigation, and we're going to hear a lot more about that later on after the coffee break. So medicine, and particularly when you're investigating inherited arrhythmic syndrome, is a narrative art. You've got to be willing to sit in the room and listen to a good story, and you want to hear the story from start to finish as long as it can be told. What are the symptoms of the person who's presenting, who's being investigated for long QT syndrome? Often they may describe palpitations, and often they may feel very dizzy with these, sudden onset and sudden termination. People may report repeated episodes of blackout or syncope. And often they may describe periods where someone witnessed one of these events and thought it was an epileptic fit or a seizure. And if you go back through the literature of long QT syndrome, back to Jervell and Lange-Nielsen's very first paper in the late 1940s, the children were all misdiagnosed as epileptic, and that still continues today, which is why, as Dr. Walsh was saying, all these patients who come through most institutions now will get an ECG. And we know that there may be certain triggers that lead to events in certain different types of long QT syndrome. In long QT1, it could be exercise and particularly swimming. I remember as a junior fellow sitting in London in a clinic investigating a 10-year-old boy for long QT syndrome, and his mother said, I said, "Does any conditions run in the family?" And his mother said, "Me and my sister have swimming epilepsy." Well, there is no such thing as swimming epilepsy. It's called long QT syndrome. So things have been misdiagnosed over the ages. And as we were talking about earlier with long QT syndrome, often auditory or emotional stimulation. So waking up to a sudden loud noise, an alarm clock, a telephone, etc. And again, we know the association of deafness, but that's much more rare in people who inherit 2 copies of the abnormal gene for long QT syndrome. So the family history, as we heard about, is the key thing. So if I'm investigating, or we're investigating, a 16-year-old girl who's had an episode of syncope, so she blacked out, 50% of teenage girls and 33% of teenage boys will have loss of consciousness at some stage, usually in late teenage life to their early 20s. So getting the history is very, very important. We ask about her mother, her 3 siblings. What about her siblings? She has a brother who has a 15-year-old child who's well, and she has another brother who has 2 children who again are well. But then another sister who's younger, and her son is currently being investigated for exertional syncope. So syncope during exercise, again, makes us more worried about some kind of inherited cardiac condition. And as we often go back through the family history in more detail, we may find something that's much more significant, so the death of a young child, potentially swimming or during exercise, and that completely shifts the balance or the probability that this patient has a condition like long QT syndrome compared to just the vast majority of people where syncope is a benign event. So it's all about taking a detailed family history and going back through as many generations as you can. And that, of course, affects the prior probability with which we assess patients. So here are 2 identical families. They both live in Massachusetts, for example. They both have a son who has a QT interval of 455 milliseconds, which is within the normal range for, say, a 15-year-old boy. However, if one of the mothers has long QT syndrome, the odds that this young gentleman has long QT syndrome is 1 in 2, where if they don't, then he goes back to the population odds of 1 in 2,500. So it's all about the family and what risks people walk through the door into the clinic with when you're investigating inherited cardiac conditions like long QT. This may sound a very basic point, but measuring the QT interval on the ECG is key. And it's frequently done either measured too short or too long. And there's a very, very simple way to do it. This is a very nice study from a Dutch group where they took 150 medical students and they showed them how to measure the QT interval. And they did it at baseline, and they gave them this picture, and they said, this is how you measure it. And they then compared 4 ECGs with long QT experts from around the world. And the medical students, when they first did it, were pretty accurate. They were 71%, and then 4 months later, without the picture, they were 77% concordant with the long QT experts. They were agreed with them in the vast majority of situations. That compared very well compared to only 62% of arrhythmia experts and 25% of cardiologists and non-cardiologists. So by and large, this paper very nicely showed it's not something that's done very well. If you include the U wave, you can have a significantly long QT interval, and that can change the diagnosis. So accurate measurement of the investigations and the QT interval is key. As we know, the ECG, as we said, is very, very important. Not only do we look at the QT interval, but as Dr. Walsh was showing earlier, we look at the shape of the T waves. And this is a young lady with long QT2, and you can see, as it's often described, speed bumps in the road, that rather low amplitude, bumpy T wave, which again is very characteristic of long QT type 2. So not only the QT interval itself, but the shape of the T wave gives us lots of clues. But as many of you know, the QT interval can be completely normal in many patients who have a genetic predisposition to the condition. And in fact, as many as maybe 60 or 70% of long QT patients with long QT1 will have a normal resting ECG. So what we have to do is to put them through a protocol which stresses the heart and may bring out that QT prolongation. So all our patients come to us and they go through our QT protocol, and we ask them to lie down, get nice and relaxed, and the first thing we ask them to do is to stand up. This is a completely normal looking T wave with a normal QT interval. On standing, there's a significant change both in the shape of the T wave and its length. So just the simple task of standing up stresses the heart sufficiently that the QT interval becomes long, and that can give away the diagnosis. And then we measure the QT interval during recovery. Again, and you can see here it's still very long in recovery from exercise. So about 480 milliseconds is the upper limit of normal for an adult female. So both these measurements were way above the upper limit of normal and gave away the diagnosis in this family. And then we can plot that on a graph, and we know that most people, or the vast majority of people, shouldn't exceed 490 milliseconds for the QT interval when standing. And in the early recovery phases, it shouldn't go above about 482 milliseconds, and that's the vast majority of the population. So we can use these simple graphs to pictorially display the QT interval in responses to just very simple stress, such as standing and exercise. And I think someone was asking earlier, why does auditory stimulation lead to symptoms in patients with long QT syndrome? Well, if you suddenly stand up, your heart rate increases because of the gravity effect to pump blood to your head, and the QT interval takes longer to what we call accommodate or to shorten than it does for the heart rate to speed up. So we see this paradoxical prolongation of the QT interval, and maybe with sudden noises, that's what stimulates this effect. And obviously, the longer the QT interval, the more likely you are to have a cardiac event. So other investigations, as we heard, is the family. We know from investigating 20, 25 years ago, as you heard in Dr. Walsh's talk this morning, the key to understanding these conditions was looking at big families, looking at very, very extended pedigrees, and that allowed us to identify the genes, and from the genes we were able to identify the proteins. But I think I would really urge that we sort of now go back and continue to use the family as the investigation of care. Genetic testing we've heard about can be incredibly useful. It's an incredibly supportive test, and it can allow us to understand both the biology of the disease and also to track it through families. But like any investigation in medicine, there's no perfect investigation. They all come with a caveat. So we all have genetic variants in the reading frame of our DNA. We all are walking around with about 100 major genetic mutations in our DNA. We all have them. So what our job is to distinguish between what's truly causing the condition, what's causing long QT syndrome, and what's just background noise. And about 4 to 5% of people will be walking around with no family history or no personal history of long QT syndrome, but will have changes in these genes. And these have now been examined in great detail, and we're able to use databases from control populations to reference against if we identify genetic changes in any long QT patients. As we said, this is best done in the context of the wider family, where we can segregate these variants through the family. So if the genetic change is associated with long QT syndrome in every situation, then that's very, very powerful statistical information that this is a disease-causing change. And then we can use that to screen asymptomatic family members at a young age and say you may or may not be affected by long QT syndrome. In terms of the treatment, we know that with the condition there is very significant variability in the clinical picture, even within families harboring the same genetic change. And these can be patients who are highly symptomatic at a very young age, even in fetal life, to people who go through life without ever knowing they have the condition. And I've diagnosed long QT syndrome in an 82-year-old who said, "That's nice, dear." She was in London. So we have to highly individualize our treatment strategies. You have to manage the patient that we see in front of us. And that involves lifestyle modification, medical therapy, surgical intervention, and also device therapy, and I'm going to quickly whiz through those now. I think if there's one rule of thumb that you can apply to every long QT patient, as we talked about earlier in the second talk, is avoidance of long QT or QT prolonging drugs. And I'm sure you're all familiar with this website. Why is this important? Because many of these agents interfere with the channel IKR that conducts the potassium out of the cell and allows the cell to reset, and that can significantly prolong the QT interval. So often we have families who had no idea that they had long QT syndrome. Someone has appendicitis and gets an antibiotic in all good faith, and the QT interval prolongs, and then we identify the rest of the family. So avoiding these medications is absolutely key. Another important lifestyle modification is exercise and sport. We're going to talk about that a lot more this afternoon. Why am I showing you a picture of hot mud? Is a good question. My 4-year-old son loves to play in it, but obviously exercise and avoidance of exercise is extremely important. This is actually sport. This is the sport I play, or did, many years ago. So this is rugby, and I show this because it's a very important day. Because as we're talking, England are playing New Zealand. This is the New Zealand rugby team, who do this tribal dance called the haka before their games, which is steeped in the Maori history. It's a very dramatic thing that they use to their advantage very, very well. But it's always at the beginning of games and always gets the crowd going. So it's a great thing to see and a great spectacle. And for those of you who are worried, New Zealand are 16-14 up as we speak. I'll keep you posted. Anyway, as you all know, beta blockers are the mainstay of treatment for long QT syndrome, and in the right patients, they can be highly effective. This, from the early data that came out, there was a sort of a failure rate at best of maybe 10%, the best responders showed a 90% response to beta blockers, but there were some important caveats that those early studies didn't address that this study did. And what they show that in patients with long QT syndrome type 1, beta blockers are highly effective. And if patients are compliant with medication and avoid long QT or QT prolonging medications that they shouldn't take, then beta blockers are very, very good treatment for patients with long QT1 and also to a degree with long QT2. So the only symptomatic patient in about 215 patients was a little boy who actually had Jervell-Lange-Nielsen syndrome, which is very different in terms of the risk stratification from the more common type of long QT syndrome that we see. So even in this study where I think about 24 people had a cardiac arrest, none of them got defibrillators and could be successfully managed with beta blockers following their diagnosis. So in the right patients, it's a highly effective treatment and is the mainstay of how we manage the condition. For patients who, some patients can't take beta blockers, or some patients may need a little bit more, as Dr. Walsh was alluding to earlier, we can do this, which is a cardiac sympathectomy, where we divide the nerves that supply the heart, or we don't, the surgeons do divide the nerves that supply the heart, and those actually release the adrenaline or epinephrine onto the heart and stimulate it. So it's like a surgical way of beta blocking the heart, and both will be seen as anti-adrenergic therapy. So they have a similar and potentially complementary effect, and this is often the second stage that we would now employ if we're worried that beta blockers aren't being completely protective in different patients. In terms of device therapy, I think one of the things that we're using more and more is this device, which is called the Reveal device. This is effectively the second generation of this device, and the reason it's become so much more useful is it's about 80% smaller than the first generation. So this is now about the size of a paperclip. So it's extremely small. We put it under the skin, and it records the heart rate and rhythm all the time. So if we're concerned at all about patients who may be still having symptoms on treatment, This is a very good way to work out exactly what those symptoms are, because everything is transmitted to us, and we give all our patients a device that plugs in by the side of their bed, and every time they go to bed at night, it downloads this information and sends it to us automatically. So it's a very powerful way of us being able to remotely assess heart rhythm in anyone that we may be worried about. We still do use pacemakers. Just pacemaker therapy can be very important. This was a lady I looked after in London. She was in her 60s. She'd had the most fascinating life history. She was of Indian extraction, but she'd worked as a truck driver in Tanzania. You name it, she'd done it. It was incredible. 10 children. But she'd had about 25 blackouts during her life, and she fortunately had one for us in the emergency room, and this was her ECG recorded at the time. And what you can see here, this is the very dangerous rhythm called torsade de pointe that we've seen already, that we associate with long QT syndrome, that causes people to lose consciousness. And it's often this irregularity of the heart rate that leads into that. So by stabilizing the heart rate with a pacemaker and just keeping the heart pacing or activating at a steady rate, that in the right patient, again, can significantly eliminate these symptoms. So of course, the final trick up our sleeve is to use ICDs. ICD therapy can be very, very effective in the right patients, and it only needs to work once to save your life. So our job as physicians is to understand who's at the highest risk, who actually potentially needs one of these devices. So potentially those with very severe QT prolongation, often who present early in life. Of course, and that's, as Dr. Walsh was saying, are the most challenging group, as ICDs are designed for adults, not for 2-year-olds. Symptomatic patients who still, despite beta blockers and sympathectomy, may continue to have worrying episodes of palpitations or blackouts. Those who presented with a cardiac arrest, but potentially not in all patients, particularly long QT1 syndrome. And also to those who present again at a young age or who have a very severe evidence of the phenotype. And this was a young boy I was involved with in London who was 8 years old. His father said he'd taken all the kids out for dinner and said, okay, come on, you can all sleep in my bed, as we all do. And he woke up in the middle of the night, and his son was having a seizure, or he thought was having a seizure. Took him to the emergency room, and this was his ECG. And I don't know how well this is the contraction of the heart, and there's an extraordinarily long pause before it relaxes again. So this is very, very, very severe QT prolongation. So this is the sort of patient we would be worried about would go on to have more and more life-threatening events, so he got an ICD early on. So this is the very severe end of the spectrum. How are they implanted? What do they do? Well, this is just a cartoon of the heart. You can see we have the two collecting chambers, the right atrium here, the left atrium, the left ventricle and the right ventricle. And we can put 1 or 2 leads into the heart, and they're screwed into the muscle at the bottom of the heart, and they will sense every beat that the heart has, and it'll send it back to the generator, which is stored up here, which is just a very expensive computer, and we can investigate all that information, and we can program the device to treat the patient if they have an abnormal heart rhythm. But not everyone is suitable for those devices, so we have to sort of do amend when we can. In a young patient, we may use an ICD lead, but pacemaker leads screwed onto the heart to allow to actually just sense the activity of the heart, because this lead is running round behind the heart and acts as the vector for the shock between the generator, which sits down in the abdomen, and the lead that's behind the heart. But in the last year, we've had a new device released, it's been approved by the FDA, called the subcutaneous ICD. And there, the generator or the battery sits in the chest wall, out here on the side, and the lead runs across the front of the ribs and up the front of the sternum or the breastbone. So that's incredibly advantageous for many patients because it doesn't actually go into the system, it's not inside the heart, so it eliminates many of the problems that we see, such as infection and trying to get these devices out again should we need to. So that's a very new and potentially helpful tool for many patients, particularly with long QT syndrome who don't need the heart to be paced on a regular basis. So what does the ICD do? Here you can see we've got 2 leads in the heart. We've got one in the top chamber, one in the bottom chamber, and it's recording. This is the heart beating, and this is the ICD recording it. And here you can see this is nice, normal sinus rhythm. The top chambers are beating, and the bottom chambers are beating. And then we have a surrogate ECG recorded here from the device as well. So of course, what we want the device to do is to detect when there's an abnormal rhythm. Here you can see this is ventricular fibrillation, the situation we worry about in many conditions like long QT syndrome. And here you can see the bottom chambers are beating incredibly fast at about 300 beats a minute, and the device is going to detect that and give the patient a shock to restore the rhythm back to normal. But obviously, ICDs are just a very expensive computer that can do all sorts of clever things. I think it's a misconception that they can diagnose heart rhythms. They can't. All they do is they do what we tell them to do. So the key to good ICD therapy is in the programming. And when an ICD comes out the box, it's pre-programmed for a 75-year-old man with ischemic heart disease who's had bypass surgery, etc. So we need to make significant changes for young patients with long QT syndrome, because what we don't want is the situation where the device here thinks there's an abnormal rhythm because the heart is beating fast, but it's a normal fast heart rhythm, and this child was just playing. They don't want a shock when they're just messing around and having fun. But of course, we know there are many complications associated with these ICDs. So they're not right for everyone. For some reason that didn't play, but this is a large infection on the ICD, so they're certainly not for everyone, and we need to risk stratify patients very carefully to make sure that the benefits of the device outweigh the potential complications. And also, as we know in children will grow. There's nothing we can do about that. Oh, there we go. It's beating now, sorry. So you can see, here's one of the heart valves. Here's the right ventricle. Here's the right atrium, and you can see these big clots that are formed on the ICD leads, and these were infected, and the whole system had to come out. So they're not without their complications, so it's very, very important that they're implanted into the right patients. And again, you can see there's a little damage, little nick in one of the leads here, and again, that can lead to significant problems, particularly the device shocking the patient when it shouldn't. So just to conclude, the diagnosis is based on personal and family history. I always tell our trainees get a really good story, and also examining the ECG both at rest and with provocations such as standing and exercise. The key to the diagnosis and investigation lies in the family, and it's very important. We always warn patients genetics is probabilistic, not deterministic. It's part of the jigsaw, it's not the final answer. Beta blockers are a very effective therapy for the vast majority of patients, and we reserve ICDs for high risk or refractory cases. I'd just like to acknowledge many people who've been incredibly helpful and supportive, not only to me, but to the whole program after the last few years, particularly Ed Walsh and the whole division of EP, how they tolerated a Brit in their departments who looked vague and blank when they were talking about a Red Sox shutout the evening before, didn't know what they were talking about. Jim Locke and other members of the cardiac department have been fantastic, and also colleagues from Massachusetts General, the Brigham, and the Beth Israel. Also the team who've organised this fantastic symposium today, who you will be seeing around during the course of the event, and to acknowledge and thank all today's speakers. And I will just leave you with this final picture, mainly because I like it. It's a beautiful picture. It's drawn by a native Canadian artist, and it also importantly illustrates the point that conditions such as long QT syndrome can exist in certain regional areas. And long QT syndrome is prevalent in British Columbia, in the Canadian natives, and this is a loon, and it's in the classic local art, and this mother has long QT syndrome as depicted by her heart with a line through it, as does one of her babies, but the other one doesn't. So it shows the autosomal dominant inheritance of long QT syndrome. So thank you very much for your attention. I'll let you all get a coffee, and we're very happy to answer questions throughout the coffee break. Thank you.